Chapter 4 is kind of the culmination of chapters 1, 2, and 3. We're actually going to get into functional activity rather than just looking at theoretical activity. Remember now, next session, we'll be jumping ahead to chapter 19, which is, or section 19, which is the interaction of psychology and the law and the legal system. So we go 1, 2, 3, 4, 19, and then we jump back to 5. And the reason I do that, again, is simply because that gets all of the more procedural things out of the way at once. And then we go and we spend the rest of our time looking at actual diagnostic pathological issues. So it kind of chunks things together. According to the syllabus, we would be having our first exam. I think this is week 4, so normally we'd be having our first exam. We will not have our first exam this week. It will be posted actually next week. So that is a modification to the syllabus and to the calendar, primarily because we got started a week late for this course. So I want to make sure that we're ready. So next week I will go over kind of a quick review over what we were looking for. And this is an online exam, okay? So it's not a proctored exam. It's one that you'll be able to do wherever you want. And I'll go over it with you beforehand, okay? So just know that it's going to be over chapters 1 through 4. I will not include 19 on it because that's going to be new content. And I don't want to bog you down with that, but we will lecture over 19 next week. So you kind of know what the layout is. All right. If you have any questions, throw them into the chat room. I have that open. And if you need anything, you can always email. But let's go ahead and get started on the lecture for today, which is, again, about kind of the overarching ideas without getting into specific diagnoses. What is the actual assessment, diagnosis, and treatment protocols in this very unique medical model that we use, okay? So remember, just a quick review, the medical model is something that is overarching to everything. The medical model is we take symptoms. So somebody walks in the door and they say, I have symptoms X, Y, and Z, okay? So let's not even think about psychology here. Let's think about somebody walks into a doctor's office and says, I've been sniffling, I've been sneezing, I've been coughing, I have body aches, haven't been able to sleep well, okay? Those are symptoms. The doctor or anybody who's seen a NyQuil commercial can easily tell you that that is cold and flu symptoms. So the doctor is going to take those symptoms, add them up, and say, okay, boom, you have the flu, you have the cold, you have something. Okay, so that's a clinical assessment. The term clinical assessment doesn't come from where it takes place. It normally does take place in a clinic, but a clinical assessment is a non-invasive assessment. It is an assessment that is based upon someone's clinical observations, okay? So if I put somebody in the fMRI machine, that is no longer a clinical assessment. If I ask somebody their symptoms and I come up with a diagnosis based upon that with information that they've given me, that's a clinical assessment. The minute that we start becoming invasive and we start doing, some advanced testing, that's when it goes out of a clinical assessment and goes into more of a medical assessment, okay? So we take the symptoms, we come up with the diagnosis, and then we come up with what we feel is the best treatment to address whatever symptoms the physician or the psychologist or the psychiatrist would want to address. Okay, so it may be the simplest ones, it may be the ones that are the most problematic, it may be the ones that have the best potential for symptom reduction. It just depends on what the therapist, the psychologist, psychiatrist, whoever the healer and the healer-patient relationship is. They're going to make that decision. Can I ask what covers 1 through 4 you're talking about? What this thing that covers 1 through 4 is. Wallace, I'm not sure what you're asking. I think what I was talking about there was next week at the beginning of lecture, I'm going to go over and review sections 1 through 4, so that we're prepared for that first exam that's going to open up next week. Okay. There was no assignment or anything. It was just, that's what we're going to do next week at the beginning of class. Okay. Okay. So hopefully I can get this word. Okay. So clinical assessment. Basically, in this world of abnormal psychology, we're looking at what is going on with the individual person. So it's idiographic. We don't care about a global assessment of people. That's the research psychologist. We're now into the treatment and clinical-based psychology. Okay, so while we care about, you know, all people in a very, you know, loving and humanistic way, we only care about the individual when we're treating that individual. Okay, so the clinical assessment is basically, why is this person acting this way? When is this person acting this way? And how can we change it? So this goes all the way back to the first lecture of Psych 101, describe, explain, predict, control. Okay, describe what's going on with the person's behavior that's maladaptive. Explain how it's maladaptive and maybe what's going on. Predict when these things are occurring, they act differently. So, you know, if it's schizophrenia, when the dopamine levels are excessive, or maybe for a chemical dependency, when people are stressed out, they tend to use more chemicals. And then control is the treatment aspect. Okay, so if there's only 8 words that you leave Psych 205 with: describe, explain, predict, control, dysfunction, danger, distress, deviance. Those are our 2 kind of diamonds of what's going on in clinical psychology. If you conquer those 4 or those 2 quads of words, you can at least talk knowledgeably about abnormal psychology and psychopathology. You'll understand, if you really take the time and focus on those two quads of words, of terms, you'll be able to apply it very easily into the individual diagnosis. It's not going to be so complex to try to remember all the different diagnoses and what's going on. You can just kind of apply those four terms for each. Okay. So what are we doing in this assessment? There's 3 basic things that we can do for an assessment in psychiatry and clinical psychology. The one that is probably the most prevalent in a formal setting is the clinical interview. Now, to be perfectly honest, the one that is most prevalent in the real world is the observation, because we observe what's going on. Even non-psychologists observe what's going on and can explain, so they can describe and explain what is going on. You know, they look at their child and they say, you know, you're just not acting the same as they used to. You look at your significant other and you say, you act differently. You seem different than you used to. That's an observation. And that is a huge part of the clinical assessment, because as a clinical psychologist, I may get an hour or 2 to try to figure out what's going on with somebody. So I really have to get as much information from other people to know, because I just can't follow somebody around 24 hours a day to get a really good clinical picture of what is going on. So the clinical interview is that initial, a lot of times we call it an initial assessment. Clinical interview, initial assessment, basically it's information gathering so that we have a good understanding of what is going on with the individual that is sitting in front of us. And a lot of times, this is probably the most frustrating aspect of treatment, because a person comes in, and a lot of times they've set up appointments 3 or 4 times and never showed up. You know, like if they have depression or anxiety, they've made the appointment, and then when the time came, they just didn't show up because they didn't want to. And finally, they walk in the door, and we spend an hour getting all of this information from this person that it feels like, A, it feels very invasive, and B, it feels like, you know, I'm here because I'm depressed. I want to talk about my depression, and you're asking me about my family's health history. Why are you going over this? Well, it's important because these are pieces of information that we need to know. We need to know if there's some health history. We need to know if there's some psychiatric history in the past. So that's what the clinical interview is all about. If we need more pointed information, if we need more specific information, that's when we throw tests into the equation. Okay, we don't just throw tests in the equation just because. That'd be the same thing as if you went in for a pain in your stomach. The doctor's not going to just give you like 10 different tests. Like, okay, well here I'm going to give you a stress test. Hop on this treadmill. Let's see how your heart does, and then let's put you into a CAT scan and see what your brain looks like, and then let's probably take some X-rays of your ankles because what the hell. We do these specifically. They're set up because we need to know specific information. So tests are after the clinical interview and after observations. The tests are basically to figure out, does my clinical interview, does my observation match up with what a objective test may also say about this individual? Okay, so we'll talk about tests in a little bit, but just to kind of get you thinking the right path, the Wechsler Intelligence Scale for children, the Wechsler Adult Intelligence Scale. That's the IQ test that we commonly call it the IQ test. The ink blot test, everybody's heard the ink blot test. It's actually called the Rorschach test. There's many other tests like the MMPI. If you've ever taken the MMPI, you know it because it is the longest psychological assessment that I can think of. It's over 500 questions. And by the end of it, if you weren't feeling a little loopy and a little nutty before you took the MMPI, you will after taking it, because after 500 questions, it asks you the same question over and over in like 7 different ways. And by the end of it, you're like, I know I've answered this question before. And the whole point of it is to figure out if you're basically, if you're consistent with your answers. So there's all these different tests that try to figure out different things. And each of them are specific to a diagnosis, and each of them are specific to a certain treatment option that may come up. So what is a characteristic of a good assessment tool? Now, there's a lot of assessment tools out there, and not all of them are good. The big word that you're going to hear in this is the same as what you hear in research. A assessment tool must be standardized and have 2 big things, and you've heard this in every science class you've ever been in your life. I took my daughter to a Science Alive thing this weekend at the public library where they brought in dozens and dozens of different sciences, from robotics to aeronautics to biology to botany, all kinds of different stuff. And to a T, almost every one of them talked about standardization. They talked about reliability and validity. Maybe they didn't use those words, but they talked about it because that is the language of science. So these techniques that we use have to be standardized. They have to be something that if I administer the test, it's going to give me the same results as somebody else who administers the test. And the 2 big keys here are reliability, and let's go over that first. Reliability is basically, if I give you the test today and I give you the test in a month, I should get essentially the same result if nothing fundamentally has changed with you. If I give you an IQ test today and I give you an IQ test in 3 months, you should score within about 5 points, unless something has happened. Like maybe somebody has a stroke, maybe somebody has a traumatic brain injury, maybe somebody started playing in the NFL and has CTE, and their mind is starting to have trouble recalling information. CTE doesn't happen that quickly, but something traumatic happens. Your IQ shouldn't change unless something big happens. So reliability is, am I getting the same score? Okay, so there's 2 different types. There's test-retest reliability and inter-rater reliability. Test-retest reliability is what I just mentioned. It's if I give you a Wechsler test today and I give you a Wechsler test in a month, you should, if we gave you that test within a month of each other, there's a good chance that your IQ could go up 5 points. And the reason for that is because of the recency of taking the test before. You may actually remember some of the questions that we gave you, and you may actually have subconsciously kind of worked through some of those questions. And so when you retake that test, you're going to do a little bit better just because of gaining a little bit of new skill or a little bit of new knowledge, but you're not going to go from having an IQ of 85, which is on the low end of average, to 130, which is on the low end of genius. You're not going to change like that. So if the retest reliability is good, it means, you know, if I give it to you now and I give it to you in a set amount of time, you should get the same score. Inter-rater reliability is probably the most important and the most overlooked. And being from a behavioral background, a lot of my work has been working with people with developmental disabilities like autism and intellectual disabilities. And we do a lot of behavioral interventions where these individuals have lots of support. They have lots of caregivers, they have lots of other therapists, they have lots of you know, occupational therapy and music therapy and art therapy and rec therapy. And if I'm asking them to keep track of the individual's behavior, we have to have a very good, what's called operational definition of what that behavior is. And to give you a great example, verbal aggression is one that is a behavior that needs to have a good operational definition, or else inter-rater reliability will be horrible. Okay, so if I have an individual who walks around the day program and just constantly is in a bad mood, constantly, you know, F this and F that, and, you know, shut your, you know, just like F this, F that, you know, this is BS. I personally would not call that verbal aggression. Some people might call that verbal aggression. Some people might look at that and say, whoa, you're being aggressive. I don't like that. But my operational definition of verbal aggression is expressive communication that is weaponized. So if you don't move, I'm going to kick your butt. That's verbal aggression. And even something is, you know, I would not call, you know, F you, F this is BS. There's option A, or if you don't move, I'm going to hit you. A lot of people would say, well, verbal aggression, the one with all the curse words, is verbal aggression, but really the one where the person just says, if you don't move, I'm going to hit you, that's actually verbal aggression. So why this is important is because if I need somebody to document how often somebody is being verbally aggressive, I need to define what verbal aggression is so that there's good inter-rater reliability, okay? Different judges are going to have to independently agree on how to score and interpret a particular tool or a particular aspect of what's going on. So if I'm giving let's say that we, on an initial assessment, we have a Likert scale, a 7-point Likert scale, which is, you know, 7 is the person appears to be very happy, their affect is bright, and a 1 is suicidal ideation. 2, 3, 4, 5, and 6, we need to have a good understanding of what it means to get a 5 or a 6 so that my 5 and 6 looks like your 5 and 6. Very important, because if I give somebody an assessment, somebody else may look at it, and if the inter-rater, if the tool doesn't give us good definitions, then it doesn't matter how great each individual person is, the tool is faulty, therefore the assessment is going to be faulty, okay? So that's reliability. Every time, if somebody is reliable, you know that they're going to show up on time and they're going to show up when they're supposed to. Reliability in assessment is, it's going to give you the same answer. It's going to give you the answer that is appropriate for that person. Validity, on the other hand, is it testing what it's supposed to test? Okay, and validity a lot of times is very simple to figure out if something is not valid, and other times it gets really tricky. If I were to tell you, for your final exam, I'm going to have you come to a campus and you have to shoot 100 free throws. You have to go to the basketball court, shoot 100 free throws, and whatever you get out of 100, that's your score for your final exam. Okay? Is that a valid test for Psych 205 final exam? No, not even close. Could it be reliable? I mean, could it be reliable? Yes. I mean, you know, if you play basketball before, you probably are going to get out of 100 law of large numbers, if you hit 60, a week later, you're probably going to hit around 60. So it's reliable, but it's not valid. It doesn't tell us anything about psychology. Okay? So there's three different types. There's space, concurrent, and predictive. Space is what I just described. Okay? It's measuring what it's supposed to measure. Okay? If I give you an exam, if I open the exam for the first 4 chapters of Psych 205 next week, and the first question you see is about the American Civil War, we have poor face validity in that assessment. But if the first question is list the 4 Ds of abnormality and give an example of each, that has good face validity. It's telling me, if you can answer that correctly, that you know a piece of information that's valid to this course. Okay? Predictive validity, an assessment may have good face validity, but it really doesn't give us good predictive validity. Everybody, I would assume, has taken at some time or another one of these 3 exams. You've either taken the ACT, the SAT, or if you're from Indiana, you've taken the ISTEP. Okay? Those are supposed to have predictive validity, especially the SAT and the ACT. They are supposed to predict how well you may perform in a college situation. It is not, the SAT and the ACT are not supposed to have face validity of whether you're a smart person or not. People equate a good score on the SAT to being smart, but that's not really the test. It's the predictive validity of whether or not you will be successful in college. And that's why it asks the certain questions that it does. A lot of people look at it and say, just because when I was a senior in high school, I could not do these SAT questions, that doesn't mean that I couldn't go to college and do it, but it's really assessing your college readiness. Okay? I think everybody in this class has probably taken the AccuPlacer or some form of the AccuPlacer here at Ivy Tech, and that is supposed to have a predictive validity of how well you'll do in specific math classes or English classes or communication classes. If you score X, if you score between X and Y, you get placed into 0 level courses. If you score between Y and Z, you get placed into like Math 136. Hopefully our assessment tool is good, and it tells us that, hey, yeah, it's predicted that you will do well in this class. Not always is it going to, because sometimes you may just be a really good guesser. Maybe you actually freaked out. This is normally what happens. People freak out during the test and they do poorer than they should have. And so the predictive validity doesn't give them kind of the bump that they should have. Okay? And then concurrent validity is basically whether the tool matches what we actually see in real life. So if I give a personality assessment and it tells me that I am extremely extroverted, but I look at my behavior in daily life and almost everything points to me being an introvert, then either the test has bad concurrent validity or I didn't answer things correctly. And to be perfectly honest, a lot of these tests, people don't answer. They answer in the way that they want to be seen, or they answer the way they think they're supposed to, and the concurrent validity becomes kind of a problem. All of these assessments that we're going to talk about have been tested over and over for face validity, predictive validity, and concurrent validity. Does that mean that they're always going to be perfect? Absolutely not. A lot of it has to do with the administrator. A perfect thermometer, for those of you going into nursing, or I guess anybody who's just ever used a thermometer, which I would hope is everybody, the perfect thermometer might give you the wrong temperature if you don't put it under your tongue correctly. Like if you just stick it in your mouth on top of your tongue, it's not going to give you an accurate temperature. But a good thermometer that is used correctly will give you an accurate temperature. So we have to look for reliability and validity in all of our assessments. Okay? So those are the big things we're looking for in the test. Now, let's go back and let's talk about the clinical interview. The clinical interview is usually a face-to-face encounter, and it's usually the first contact, unless there's an emergency and you may skip the clinical interview. But for the most part, this is usually like session 1 or session 1 and 2, where the clinician will go over questions and kind of get a background information and find out what's going on with this individual. If you were to sit and listen to 20 clinical interviews, and my goodness, that would be a boring 20 hours. But if you were to sit there and do it, the one thing you would figure out more than anything is that every interviewer is going to ask questions based upon their theoretical orientation. A psychiatrist is going to ask more medical questions. A behaviorist is going to ask more about what a person does throughout the day. A cognitivist was going to think about, what are you thinking? A psychoanalyst is going to ask about your mom and your childhood. You're going to see there's going to be some things that are going to be universal, like, your name, your age, gender you identify, all these different things. But then some of the specific questions are going to be able to show you if the clinician is oriented in one way or another, okay? There's a lot of different ways to do these interviews. The two big differences can be a structured or unstructured interview. And, excuse me, the structured interview, if you've ever been to any facility, any large organization, so like a community mental health center around here, it's like Swanson Center, Porter Stark, Oak Lawn, for those of you that are from different areas, whatever your community mental health organization is, or even your bigger hospitals, they're normally going to do structured interviews because they have an intake form that everybody uses. And a lot of times that's because you have an intake specialist who's actually doing the clinical interview. They're people who that's all they do. They're very good at doing the intake interview, and then they pass someone along, they pass the client along to somebody else who will actually do the treatment. So in a structured interview, it's prepared questions. Usually it's a form. You may do a mental status exam. So some of the nurses may have actually touched on this before in some of your classes, or you may have done this if you're in human services. The mental status exam, if you've ever been asked, what's your name, what day is it, where are you? That is a mini mental status exam. Basically, seeing if you are aware of who and where and when you are. This is also kind of some of the first questions that somebody would ask in a concussion protocol. So the mental status exam is kind of like the beginning of the concussion protocol. If you get your bell rung, like the guys who were playing football last night in the Super Bowl, if they took a helmet to the head, the first thing the doctors would ask them is, do you know where you are? And if they were to say, they look around like, yeah, I'm on a football field, but I don't know. If they can't remember they're in the Super Bowl, something has happened. They probably definitely have a concussion. And so you don't need to go any further. You don't need to ask, you don't need to do any more diagnostic. You need to deal with the concussion right there. Okay. So the structured interview is very similar. If somebody is not aware of who and where and when they are, you don't need to ask them if they're depressed or if, what's going on with their family. You need to get them into some acute treatment at that moment because they are actively psychotic or demented in some way. Okay. In the unstructured interview, the clinician will ask open-ended questions. Like, some clinicians, who are in private practice may sit down with the individual and just say, tell me why you're here. Tell me what made you pick up the phone and schedule an appointment with me. And then eventually they'll get to those more standardized questions because you have to have them. But the unstructured interview allows the patient or the client or the potential client to really kind of unload. And sometimes I've done an unstructured interview where I'll say, why are you here today? And 45 minutes later, I have to cut them off and say, okay, I need to get a little bit of information here. I need to know your name. I need to know your address, your age. Because literally, I will have somebody who I know their name because they scheduled an appointment, but they haven't said their name. They haven't asked me who I am. They've just been waiting so long to have somebody sitting across from them who cannot walk away during their story, but they're just so happy that they just unload. And that's an unstructured interview. And there's a lot of power to that. Sometimes people just need to unload and then we can go from there. But in a community mental health situation where you're going from an intake coordinator to a therapist, getting that unloading is not relevant, because that person's going to have to unload a second time when they get to the therapist. So the structured interview is so important, because you get the formulaic stuff and then you can pass them on and they can unload to the treating clinician. The limitation of a clinical interview, let's be perfectly honest, sometimes people coming in for mental health treatment, psychiatric treatment, may not be the most accurate or valid storytellers. We have a great name for this, is inaccurate historian. That's a really nice way of saying somebody either their pants are on fire, or they don't have the wherewithal to actually remember what's going on. If you've ever worked in like a nursing home, think about the clinical interview you would do with grandma or great grandma coming in. Maybe they're suffering from dementia, early onset Alzheimer's. Are they going to give you the most accurate details? No, they're going to give you some awesome stories, but they may not be in touch with reality whatsoever. So there may be some accuracy issues. The interviewer may be biased. I know that when I was doing clinical work full time, there were times where by the end of the day, if I was getting an intake and I've already had like 6 sessions, and I get number 7 walking in the door for an intake and they start telling me their story, I would almost fast forward in my mind and say, okay, I had 2 of these today. Like, I can get there already. I already know what's going on here. And so I may be biased because of all the things that I've heard that day. That's not a good way to do it, but therapists are human, psychologists are human, psychiatrists are human. And so we might mistake where somebody is going based upon our previous interactions with people. And unstructured interviews may lack reliability. Think about it. If you tell your story, think about you have to tell a story about your first week at Ivy Tech, and you sit for 45 minutes and you tell your story of your first week at Ivy Tech, and then a week later I want you to tell me that story again. It may not be the most reliable story, and it's not because you're lying. It's because you're focusing on different aspects of the story. You're remembering things slightly differently. You're in a different mood. We may have a reliability issue, okay? So let's get to something a little bit more hard and fast, and that's the clinical test, okay? Clinical test, a lot of times I'll defer to the old term that we use, which is psychological test or psychological assessment, but we call them clinical tests now. The amazing thing about clinical tests there are more than 500 clinical tests that are in use, and no clinician is well-versed in all 500. I would say most clinicians are well-versed in about 10 to 15 that they use consistently, okay? And so it depends on your orientation. If you're a behaviorist, you're going to do a lot of applied behavioral analysis, a lot of functional behavioral analysis. If you're a psychoanalyst, you're going to use more projective tests. If you are, a state-funded clinical psychologist looking at, if you're like one of the Medicaid psychologists who determine whether somebody qualifies for funding, special funding, you may just be considered about aptitude and intelligence. You're going to be well-versed on those clinical tests, but you're not an expert on all the different tests. So we're going to break these down into different categories, okay? The first category is really usually the one that students find the most interesting, yet it is the least reliable, and that is the projective test, okay? I know you've all heard of the Rorschach test or the ink blot test, and if you haven't heard of it, you at least know what I'm talking about. There's an ink blot in front of you, and you say what you're seeing in that ink blot. And then there's other ones that are a little bit more, they're a little less psychodynamically bound. The TAT, the thematic apperception test, best way to describe that one, I think I have some examples coming up. The TAT is kind of like looking at the Sunday comics, but all the thought and speech bubbles are taken away, and you have to create your own story. Sentence completion tests, these are really interesting, and again, they're not all that reliable, but they give you a lot of really interesting information. Like if I had usually like 50 different sentences, and one of them might be like, my dad is blank, and I ask you the first word that comes to your head. Yesterday, my mood was blank. I always feel blank when I'm at school. I think my mom is a blank. You know, you get some really interesting ones when people get rolling. Okay, so let's look at some of these examples. So this is an example of a Rorschach plate. This is actually not one of the current plates. This is one of the older plates. And so I'm not going to ask anybody to tell me what they're seeing here, because let's be honest, that might be a little scary. But what you see is basically a projection of what you're focusing on. Okay, because there's nothing here. I mean, literally, there's nothing here. Even though some of you may be seeing, here's some common things. Some people may see, let me see if I can get my pointer here. So right in here, a lot of people will see some kind of animal, like a badger or a beaver. Sometimes people will see that. Sometimes people will see a bat right here, starfish right up in here. And if you're really clever, in every one of these plates, there is some sexual imagery if you see it. So some people will report seeing vaginas right here. Again, it's not a vagina, but if you see a vagina, then it's a vagina. And now, once I've shown you that, you can never not see a vagina there. So sorry about that. But you know, whatever you actually saw is going to be relevant only to you. And this is a very interesting test because it has been shown to be reliable, because there's actually a computer program that can actually score what you see here and what you're looking at. And it's not necessarily what you're seeing so much as what you're focusing on. Whether you're focusing on the white or you're focusing on the colors, whether you're focusing on, whether you're constantly seeing animals, or you're seeing, if you're reporting emotions, or if you're seeing people in your own family. These are all things that we take a look at as we are doing this assessment. We're taking a look at the information being given. Let me get out of here. Okay. So the sentence completion test, again, I already described this one a little bit, so I won't go over it too much, but I wish blank, my father blank. I'm looking for the individual to give me the first thing that pops into their head. And after about, you know, the first 10 or so, people are really measured. You know, my father is a wonderful person. I wish for world peace. But after about 10 or 11, 12, people start kind of just ratcheting off like the first thing that pops in their head. You get some really interesting results. There is no right or wrong answer to these, but there's groupings of right or wrong answers. You know, if every one of your responses, I wish I had a nuclear bomb, my father is the Antichrist, you know, all these different things, then you're getting into some kind of weird association. Yes, Jenny, these are psychoanalytic in nature, especially, you know, so with Freud's free association, think about going back here to this. I'm giving you a very randomized stimuli, and wherever your mind goes really wasn't, okay, so like I could say that if we're looking here, I believe these look to be like animals and these look to be like animals, but you know, if I give you 10 plates, that allows your mind to wander. I'm not forcing you by saying, you know, tell me about your dad. When I do this one, tell me, you know, my father blank. You can do whatever you want with that. My father is a farmer, or my father is tall. I mean, you can do something very superficial, or you could say something very in-depth. So this absolutely speaks to Freud's free association, because we're trying to get we're trying to get the subconscious to bubble into consciousness. That's really Freud's goal, and that's the goal with this. Just keep pummeling people with random stimuli until their subconscious finally kind of creeps out and gives you some information. There's also clinical assessments of drawing. Now, I want to make certain that I don't confuse these two things. Clinical tests that include drawing is vastly different than art therapy. Art therapy and art therapists are individuals who have a very specific curriculum. They're board certified. So if you ever see ATR-BC, that's art therapy, registered art therapist, or ATR, art therapist registered, board certified. They do very specific art therapy interventions and testing and assessments. Any clinician can do drawing assessments, like draw a person or house tree person assessment, but they're different than what an art therapist would do. So again, it's a very fine line. It's one of those things where if you're an in-group person, you know there's a huge difference between a therapist and an art therapist. But for 99% of the world, a therapist is a therapist, and an art therapist just does therapy with art. So it's a minute detail for 99% of the world, but the in-group, it's a huge difference. The good thing about a projective test is it's going to give you supplemental information. It's not going to give you a diagnosis. I'm not going to look at somebody and say, because you gave me these answers on the Rorschach, you have schizophrenia. But there are some answers that are so correlated with certain diagnoses that it can be a strong diagnostic tool. It's on a global scale, the literature says that it rarely demonstrates much reliability or validity, and that is somewhat misleading, because on an individual clinician, it can be very reliable and very valid, but it may not be, if you get a group of clinicians together in one room, it may not look as valid as like an assessment tool. Like I say, the Rorschach is not to be compared with a thermometer, because a thermometer is going to give you the same thing every single time, no matter what, and it's very precise. The Rorschach is more open, but it can be reliable and valid in a way that there is no thermometer that I can stick anywhere in any part of your body that can tell me information about your subconscious. Okay. The big thing here is you have to be incredibly mindful of multiculturalism, that you cannot assume an answer is pathological or problematic. You never want to do that anyway on a projective test. You have to be very careful when you're talking outside of your expertise when it comes to another race or culture, or even gender or gender identity or orientation. You have to be very careful, because I think the easiest way to describe that is words matter, and language matters, and culture matters. And what I may think of as being incredibly problematic is very acceptable in another culture. I may think calling my mom, I don't know, calling my mom calling my mom a bitch, and that's the only thing I can think of. I may think that calling my mom a bitch is very problematic pathologically, but in another culture, it may just be a way of calling them by a different name. And that's an awful example, but we have to just be careful of how we don't attribute our own culture and our own biases to other people when we're making these diagnoses. Okay. Okay, so the next category, let's get out of these projective tests. Personality inventories. They have the same limitations, because a lot of people don't like personality inventories, but they're more valid and more reliable than projective. You may have done a personality inventory before. A lot of people have. If you've ever done a Myers-Briggs, and even if you don't know what a Myers-Briggs is, if you've ever taken an assessment and somebody gives you a 4-letter acronym like INTP or ENFJ, that's the Myers-Briggs. And basically it gives you 4 personality types, and it's on a binary scale. So there's 16 different types you can have. For example, you either are an E or an I, an introvert or an extrovert. You're either a INTP, ENFJ, so you're a P or a J. So you perceive or you judge. And there's a lot of different pieces to that. And so there's also the 16 PF, which is the 16 personality factors that you should have been introduced to in 101. looks at the 16 different personality traits of individuals and shows whether you are conscientious or agreeable, or if you are creative or static. And then the big one is the MMPI. We just had it revised in 1989, which seems like a long time ago, but actually some of these assessments have been around since like the 60s and 70s. The MMPI is a big test. Like I said, it's like 550 questions, and it's binary, where you have to say yes or no, or agree or disagree. And again, a lot of them are repetitive to try to figure out whether or not you're trying to skew your results. So there may be 8 questions on the MMPI asking whether you have a good relationship with your dad, but it's asked in different ways. Like one may say, I have a good relationship with my father, yes or no. My father and I oftentimes do not get along, yes or no. My father and I disagree on many things, yes or no. My father and I get along for the most part, yes or no. And so most people start out the MMPI trying to be a good person, but by the end, they're relatively just worn down, and they start giving very accurate responses to actually how they feel. So it's yes, no, true, false, cannot say. And it assesses careless responding and lying by giving you so many, 550 questions, that by the end, you just can't be profound. You just can't lie anymore. You just can't remember unless you sit there and start digging back through your old questions to be able to match things up. You can't remember what you answered to number 17 when you're on number 342. So it makes a determination of, out of those 7, it gives a little bit more weight to the ones towards the end, but it also looks at, you know, whether you were consistent with every one of those answers. And sometimes if you're consistent, and it seems there's actually questions in there designed to catch people who are falsely trying to give themselves a halo effect. Like if question number 220 is, I have never lied in my life, okay? You know, I think everybody would love to say, true, I've never lied in my life, but let's be honest, everybody has lied sometime in your life. And so if you put false, I have never lied in my life, we can automatically assume that you're trying to cast yourself in a better light, okay? And what the MMPI can actually tell us is some personality traits, but the MMPI actually has been shown to be able to show some clinical scales, like depression, masculinity versus femininity, paranoia, schizophrenia, social introversion. And basically it's just gonna, if you've ever had this done, if you hit 70 points on any of the subscales, that means that you are, that you show an affinity, or you show a predisposition to one of these things. So if you scored an 80 on paranoia or an 80 on schizophrenia, it doesn't mean you're a schizophrenic. It means that you have schizophrenic tendencies, okay? What's great about personality inventories? They're quick and easy. Even the MMPI, I don't agree with this, but some clinics will just give patients the MMPI and say, go take this. And literally it will take like 2 or 3 hours and they'll come back and turn it in. I think that it should always be done in front of a clinician, but for the simplicity, if you're seeing 100 people, you may not be able to sit down for 3 hours with somebody. So it is cheap and easy. It's easy to score. But again, there's cultural issues. It is a better test than projective tests, but they're not really highly valid because you're asking a person to report on themselves. And many times people don't understand what is being asked, and they'll answer anyway. And so if I were to ask you a question and you just like choose one because it is a forced question, it's either true or false, yes or no, I may get some skewed answers because you always answer yes because you just didn't, or you always answer no because you didn't know what it meant. That's going to give me some false information. So the reliability is going to be low with that. Response inventories, these are the simplest and a lot of times the most reliable. These are basically just question and answer. They can be as little as 5 questions. They can be as much as, you know, technically the MMPI is a version of the response inventory, but it's a personality assessment. The most popular one that we use is the Beck Depression Inventory. it's not meant to try to catch people lying. It's basically just to see what level of depression you are. I think it's like 12 or 15 questions. Basically just figuring out if, you know, anything from you're having mild depression all the way up to suicidal ideation. So it's telling what's going on in those situations. They have strong face validity, but the problem is they have such strong face validity that they really haven't been rigorously tested for other types of reliability and validity, because if I ask you 10 questions speaking to depression, then face validity is there because all the questions were about depression. But the flip side of that is, you know, we don't know if it has, you know, any other correlational facets to it. So the Beck has been tested many, many times, and there's actually different versions of the Beck. But a lot of these clinical tests are basically, I would call them a quasi-clinical interview. They're closer to an interview than a clinical test, but they're structured. So the response inventory, you could say that a structured interview is a response inventory, because if I have a sheet where I have to have your name, your address, your height, your weight, your medical history, I could say that's a clinical interview, or I could say that's a response inventory. And so it just depends on what you want to call it, okay? And then there's psychophysiological tests. Psychophysiological tests are really interesting. The one that you've probably heard of before is the polygraph, which is also known as the lie detector test. And the psychophysiological has a lot of misconceptions, okay? The polygraph test, I'm going to stick on this. The polygraph test basically tests three different things. It tests your heart rate, your blood pressure, so your heart rate and blood pressure are kind of the same thing. Galvanic skin response, which is a very almost undetectable amount of sweating that occurs when your autonomic system activates, and body temperature and muscle contraction. Okay, so if I hook you up to a polygraph machine, I'm going to test your, and one thing that's not listed here is your breathing. Okay, so I'm going to put a blood pressure cuff on you. I'm going to put a tube around your chest to see if your breathing changes, and then I'm going to hook galvanic skin response receptors onto the palms of your hand and sometimes your forehead, but normally the palms of the hand are just good enough. Now, the polygraph, if you look at this from a Latin verbal way of looking at it, the polygraph, poly is many, graph is to write or to record. So the polygraph records multiple inputs, okay? So I can almost guarantee that you've heard that polygraphs are inadmissible in court, that they are not, that you can fool them, and that they are not always reliable, okay? Now, I'm here to tell you that polygraph machines are 100% accurate, completely 100% accurate, with an asterisk. The polygraph machine itself is 100% accurate. It will tell you my breathing. It will tell you whether my galvanic skin response changes. It will tell you whether or not my heart rate changes. This is old science. The interpretation of the polygraph is subject to controversy, okay? The polygraph machine itself is almost 100% accurate, but the theory behind the polygraph, that when I'm asked a question and I give a response that I know to be not truthful, that my three things, my galvanic skin response, my heart rate, and my breathing will change, that is the theory that is questionable, because that's correlational. We can't show that lying causes you to sweat, to breathe faster, and your heart rate to go faster. We don't know that. We know there's a correlation between the two. And to be perfectly honest, it's not about an objective look, like if my galvanic skin response goes from A to B, then I know I'm lying. It's more about setting a baseline, finding out how I answer when I know I'm not lying. So that's why polygraph tests always start with, what is your name? Am I wearing a black hoodie? Is your name Donald Trump? Okay, so now we've got all these different baseline tests to know, I know you're lying because you're not Donald Trump. I know you're telling the truth because I am wearing a black sweatshirt. These are objective things that are indisputable. Now I'm going to ask you the questions that we don't know the answers to. Okay, so you know, if I had O.J. Simpson sitting in front of me, we all know that he did not murder his ex-wife because he was acquitted, right? Not really, but so if I hook you up to a polygraph machine and I ask you, hey, did you murder Ron Goldman and Nicole Brown Simpson? And after I've asked him all these baseline questions, I would look for a change. Now, here's the problem with that. If I have O.J. Simpson sitting in front of me and I ask him a question about the murder of his ex-wife and Ron Goldman, might he have a physiological response just because he's mad at me asking? Yes, he might. And this actually occurred. Gotta love Indiana. Gotta love Indiana. Indiana back in the 1980s was using the polygraph test to hire state police. And they still do today, but they were asking questions, and for some reason, they could not figure out why they were getting all these people who were getting kicked out at the polygraph level, because they were finding that they were having these two questions where they were getting answers and people were they were looking as though that they were deceptive. The first one was, they asked the potential state police, the people who were applying, have you ever knowingly used an illicit drug? Okay. Now, a lot of those officers probably didn't know what illicit actually meant. And they thought either it's illegal or they knew it was illicit. Illicit basically means if you're using it outside of the scope of what you're supposed to be using it for. So, you know, if the bottle says take 2 aspirin for a headache and you take 3, technically that's illicit. You're not supposed to be doing that. So that was confusing. But then the other question, again, love Indiana, they asked a question. I don't remember exactly how it was worded, but basically it was, have you ever knowingly engaged in sexual activity with an animal other than a human? Okay. Now, as you heard that question, I can almost guarantee that some of you had a physiological response, that if I had you on a polygraph, you may have, no matter what you answer, shown to be deceptive. Because if I ask you, have you ever had sexual behavior with an animal other than a human? You're like, what? Why are you asking me this? I want to be a police officer, this is weird. But you're still going to respond because that's a strange thing. And they were getting these huge numbers of people who apparently had some weird weekends with with their pets. And it wasn't accurate because they were not testing appropriately. Okay. So long story short, polygraph, very accurate. Lie detector test, not accurate because not as accurate. It's basically as accurate as the polygraph examiner. That's what it comes down to. Okay. Other clinical tests would be like neurological tests, like an EEG or a PET scan, CAT scan, MRI, fMRI. Those things basically tell us what's going on from the biological model. So that's the kind of stuff that would be sent out to other individuals to actually have done. These are very accurate, but very expensive and very invasive. Finally, intelligence tests. We talked about intelligence tests before. The most common type right now is the WAIF and the WISC, the Wechsler. Hopefully you remember from Psych 101 the distribution of intelligence. The average intelligence in the United States, no matter when, is 100. 85 to 115 is an average intelligence. So the average is 100, and average intelligence is anywhere between 85 and 115. Normal intelligence is anywhere between 70 and 130, and then anything outside of that is considered to be abnormal. Okay, Beth, I see that you're leaving out. Completely understand. I'm trying to quickly get through the rest of this because I know I'm going to try to get these done at noon for everybody. You're not going to miss an incredible amount. So we've gone over intelligence tests, and then systematic observations. We've gone over that before. Same thing as in research. Okay. Okay. Excuse me. I feel like I've talked 3 hours worth of lecture into an hour. I know I went through these really, really quickly. I'm gonna. I think I've posted these up. Have I posted up the PowerPoints for you guys yet, or do I still need to do that for you guys? PowerPoints, are they in the class? Wait, I can just look. Hang on.
Gradebook. Hang on just a second here. So Q1P modules. I have not. Okay, so I will be posting these. I'll just put an entire module up for you that has all the PowerPoints that I use throughout the lecture. So if you need to go back and look at those, you can. I will be looking at the what are they called? Your assignments, the learning logs. But the ones that I've looked at so far, everyone's been doing really good. I actually told a couple people that, you know, if anything, and I'm not telling you to write less, but I would not tell you to write more. Most of you are writing either at the level that I would want, or maybe even a little bit further than what I would expect you to go. So I'm not telling anybody to cut back, but don't worry if you feel like you're not writing enough, you're still fine. Yeah, so Stephanie, yeah, I'll be putting the PowerPoints up. What I'll do is I'll put them at the very top of the modules. That way they're right there, even though they'll be kind of out of order for everything, they'll still be there. Okay? All right. Any questions, comments, concerns, thoughts, anything for the good of the people? No? All right. Well, email me if you need anything. I will be posting up the PowerPoints here today, and I'll be starting to grade your things. Remember, Chapter 19, moving forward. Skim through it, but if you want to spend your time getting yourself ready through chapters 1 through 4 for the first exam, that's fine too. But don't jump ahead to Chapter 5, the traumas. If you're going to go ahead, look at Section 5, which is law, the forensic psychology, essentially. Okay? All right. If you need anything, email me. Otherwise, I will see you all next Monday.